Welcome to Pharmacology Chapter 1. Make sure before or after you are going over the learning objectives in the book and the questions I have given you in the course. It's best to highlight the areas where you find the questions in the book to study for your test. Let's get started.
Pharmacology is derived from the Greek prefix pharmako, meaning drug or medicine, and the Greek suffix logi, meaning study. Therefore, pharmacology is the study of drugs and their interactions with living cells and systems. Drugs are chemical substances that are used in the diagnosis, treatment, or prevention of disease or other abnormal conditions. They can be used in both humans and animals. Drugs include synthetically derived compounds, vitamins, and minerals as well as herbal supplements, although these last substances are marketed not as drugs but as food supplements. In addition to pharmacology, the dental hygienist should know about its related disciplines, as listed and defined in Table 1.1. Pharmacology had its beginning when our human ancestors noticed that ingesting certain plants altered body functions or awareness. The first pharmacologist was a person who became more astute in observing and remembering which plant products produced predictable results. From this humble beginning, a huge industrial and academic community concerned with the study and development of drugs has evolved. Plants from the rain forest and chemicals from tar have been searched for the presence of drugs. The agents discovered and found to be useful are then prescribed and dispensed through the practice of medicine, dentistry, pharmacy, and nursing. Healthcare providers who can write prescriptions include physicians, for humans, veterinarians, for animals, dentists, for dental problems, and optometrists, for eye problems. Physician's assistants, nurse practitioners, pharmacists, and dental hygienists can prescribe drugs under certain guidelines and in certain states. In today's ever-changing healthcare environment, it is important that the dental hygienist know more than the name and color of a medication. Patients rely on the dental hygienist to provide them with the correct information regarding their medication and oral health care. Although dental hygienists do not normally prescribe drugs, it is important that they have knowledge of pharmacology and its related disciplines to provide more effective care for the patient. As a result of the many breakthroughs in medicine and pharmacy research, more and more diseases can be treated, therefore, more and more people are taking medication. More often than not, the dental hygienist is the first health professional in the dental practice to assess the patient's medication history. Obtaining a medication and/or health history is the first step in safely treating a patient. Patients may be taking any number of medications that interact with medications used in oral health care or that may adversely affect oral health. An understanding of the actions, indications, adverse reactions, and therapeutic uses of these drugs can help determine potential effects on dental treatment. Because the dental hygienist administers certain drugs in the office, knowledge of these agents is crucial. For example, the oral health care provider commonly applies topical fluoride, Chapter 26, and in some states, both the dentist and the dental hygienist administer local anesthetics in nitrous oxide, Chapter 10. In-depth knowledge of these agents is especially important because of their frequent use. The ability to recognize and assist in dental emergencies requires knowledge of certain drugs, all of which will be discussed in greater detail in Chapter 21. The indications for these drugs and their adverse reactions must be considered. For example, in a patient having an anaphylactic reaction, epinephrine must be administered quickly. Patients taking medication for systemic diseases may require special handling in the dental office. For example, asthmatic patients who experience dental anxiety should schedule their appointments early in the morning, when they are not rushed or under pressure, in order to avoid an asthma attack. Chapter 17, diabetic patients should schedule their appointments 90 minutes after meals and medication administration. Certain patients may need to take medication before their appointments. Chapter 18. Patients with a history of infective endocarditis need to be pre-medicated with antibiotics before some of their dental or dental hygiene appointments. Chapter 7. More and more patients are self-treating with non-prescription drugs. Also, non-prescription or over-the-counter (OTC) products may be recommended for certain patients. The study of pharmacology will assist the oral health care provider in making an intelligent selection of an appropriate OTC product. Although patients tend to forget that OTC products are drugs, knowledge of pharmacology will allow the dental hygienist to evaluate the patient for therapeutic OTC drug effects and adverse effects. Many patients self-treat or are prescribed nutritional or herbal supplements for any number of disease states, as will be further discussed in Chapter 24. Although the vast majority of these supplements do not carry U.S. Food and Drug Administration (FDA) approval for treating disease states, patients still use them. These supplements are drugs and can cause adverse effects and interact with other drugs. Many different medications are available, and it is important for the dental hygienist to know where to look for information about prescription medications, non-prescription medications, and herbal supplements. There are many sources, including reference texts, association journals, and the Internet, where pertinent drug information can be found. Box 1.2 reviews the different sources of information. Each publication type can be selected according to its lack of bias, its publication date, when the current edition was released, its readability, vocabulary, simplicity of explanations, and presence of visual aids, its degree of detail, all you want to know and much more, just the right amount of information, or not enough to understand what is being said, and its price. Some publications are specific for disease states, geriatric or pediatric patients, drug interactions, or prescription drugs or non-prescription drugs. Reference books can be updated monthly, quarterly, and annually. Every dental office should have at least one reference book that lists the names of both prescription and OTC drugs. Further, a standard pharmacology textbook would be helpful in understanding the reference books. Because of the continual release of new drugs, a recent edition, not more than 1 or 2 years old, of a reference book is needed. Although books serve as the usual source of information on drugs, many healthcare providers are using electronic resources, such as computer software and internet-based services. Computer tablets and smartphones are also being used more and more for recording and storing patient information, calculating drug doses, and consulting medication information databases. Many online resources are available. They include Davis's Drug Guide and LexiComp. These sites have applications, apps, that can be downloaded to smartphones as well as computer-based online sites. LexiComp also has apps specific for dentistry. In addition, many pharmacology textbooks include CDROMs that supplement the written material. Journals are another source of information that provide the dental hygienist with the most current information regarding medication and oral healthcare therapy. More than 3,000 journals are available online and can be accessed through Medline and PubMed as well as at specific journal websites. In addition, the practicing pharmacist can be a source of information. It is particularly important for the dental professional to establish a professional relationship with a local pharmacist, who may assist him or her in understanding the possible effects of a new drug on a patient. It is important for the dental hygienist to understand the ways in which a drug can be named, because he or she must be able to discuss drugs with both the patient and the provider of the patient's care. The ability to refer to a drug's names is complicated by the fact that all drugs have at least 2 names, and many have more. When a particular drug is being investigated by a company, it is identified by its chemical name, which is determined by its chemical structure. If the structure is unknown at the time of investigation, a code name, usually a combination of letters and numbers, is assigned to the product. Often the code name is used even when the chemical structure is identified and named. It is much easier to speak and write the code name than the full name of the chemical structure. If a compound is found to be useful and it is determined that the compound will be marketed commercially, the pharmaceutical company discovering the drug gives the drug a trade name, example Motrin. This name, which is capitalized, is usually chosen so that it can be easily remembered and promoted commercially. This trade name, registered as a trademark under the federal trademark law, is the property of the registering company. The trade name is protected by the federal patent law for 20 years from the earliest claimed filing date, plus patent term extensions. Although the brand name is technically the name of the company marketing the product, it is often used interchangeably with the trade name. Before any drug is marketed, it is given a generic name that becomes the official name of the drug. For each drug, there is only one generic name, example ibuprofen, selected by the United States Adopted Name Council, and the name is not capitalized. This council selects a generic name that hopefully does not conflict with other drug names. However, the names of several marketed drugs have been changed because they were confused with the names of other drugs that had already been marketed. After the original manufacturer's patents have expired, other companies can market the generic drug under a trade name of their choosing, example Advil. Figure 1.1 compares the chemical, generic, and trade names of ibuprofen. In the discussion of generic and trade names, the question of generic equivalence and substitution arises. Are the various different generic products equivalent? Once the patent of the original drug expires, other companies can market the same compound under generic name. In 1984, Congress passed the Drug Price Competition and Patent Term Restoration Act, which allowed generic drugs to receive expedited approval. The FDA still requires that the actives ingredient of the generic product enter the bloodstream at the same rate as the trade name product. The variation allowed for the generic name product is the same as for the reformulations of the brand name product. For the few drugs that are difficult to formulate and have narrow therapeutic indexes, no differences exist between the trade name product and the generic product. Therefore, generic substitution drugs give equivalent therapeutic results and provide a cost savings to the patient. Drugs can be judged similar in several ways. When two formulations of a drug meet the chemical and physical standards established by the regulatory agencies, they are termed chemically equivalent. If the two formulations produce similar concentrations of the drug in the blood and tissues, they are termed biologically equivalent. If they prove to have equal therapeutic effects in a clinical trial, they are termed therapeutically equivalent. A preparation can be chemically equivalent yet not biologically or therapeutically equivalent. These products are said to differ in their bioavailability. Before generic drugs are marketed, they must be shown to be biologically equivalent, which would make them therapeutically equivalent. Many agencies are involved in regulating the production, marketing, advertising, labeling, and prescribing of drugs. The FDA, which is part of the Department of Health and Human Services, DHHS, grants approval so that drugs can be marketed in the United States. Before a drug can be approved by the FDA, it must be determined to be both safe and effective. The FDA requires physical and chemical standards for specific products and quality control in drug manufacturing plants. It determines which drugs may be sold by prescription or OTC and regulates the labeling and advertising of prescription drugs. Because the FDA is often more stringent than regulatory bodies in other countries, drugs are often marketed in Europe and South America before they are available in the United States. The Federal Trade Commission, FTC, regulates the trade practices of drug companies and prohibits the fake advertising of foods, non-prescription, OTC, drugs, and cosmetics. The Drug Enforcement Administration, DEA, of the Department of Justice administers the Controlled Substances Act of 1970. This federal agency regulates the manufacture and distribution of substances that have a potential for abuse, including opioids, narcotics, stimulants, and sedatives. The newest federal regulation concerning drugs is the Omnibus Budget Reconciliation Act, OBRA, of 1990. It mandates that, beginning January 1, 1993, pharmacists must provide patient counseling and a prospective drug utilization review, DUR, for Medicaid patients. Although this federal law covers only Medicaid patients, state boards of pharmacy are interpreting this law to apply to all patients. Dental patients who have their prescriptions filled at a pharmacy should receive counseling from the pharmacist about their prescriptions. It takes almost 12 years from the time a drug is synthesized in the lab, oratory to its availability on pharmacy shelves, at a cost of more than $350 million. Before a discovered or synthesized compound is approved for marketing, it must pass through many steps. Figure 1.2. Animal studies begin by measuring both the acute and chronic toxicity. The median lethal dose is determined for several species of animals. Long-term animal studies continue, including a search for teratogenic effects. Toxicity and pharmacokinetic properties are also noted. This process, referred to as preclinical testing, usually lasts about 3 years. After the preclinical trials have been completed, an investigational new drug application, INDA, must be filled out and submitted before any clinical trials can be performed. Clinical studies of drugs involve the following 4 phases. Phase 1, small and then increasing doses are administered to a limited number of healthy human volunteers, primarily to determine safety. This phase determines the biologic effects, metabolism, safe, dose range in humans, and toxic effects of the drug. Phase 2, larger groups of humans are given the drug and any adverse reactions are reported to the FDA. The main purpose of Phase 2 is to test effectiveness. Phase 3, more clinical evaluation takes place involving a large number of patients who have the condition for which the drug is indicated. During this phase, both safety and efficacy must be demonstrated. Dosage is also determined during this phase. Phase 4, this phase involves post-marketing surveillance. The toxicity of the drug that occurs in patients taking the drug after it is released is recorded. Several drugs in recent years have been removed from the market only after Phase 4 has shown serious toxicity. The Food and Drug Act of 1906 was the first federal law to regulate interstate commerce in drugs. The Harrison Narcotic Act of 1914 and its amendments provided federal control over narcotic drugs and required registration of all practitioners prescribing narcotics. The Food and Drug Act was rewritten and became the Food, Drug, and Cosmetic Act of 1938. This law and its subsequent amendments prohibited interstate commerce of drugs that have not been shown to be safe and effective. The Durham-Humphrey Law of 1952 is a particularly important amendment to the Food, Drug, and Cosmetic Act because it required that certain types of drugs be sold by prescription only. This law required that these drugs be labeled as follows: Caution, federal law prohibits dispensing without prescription. The law also prohibits the refilling of a prescription unless directions to the contrary are indicated on the prescription. The Drug Amendments of 1962, Kefauver-Harris Bill, made major changes in the Food, Drug, and Cosmetic Act. Under these amendments, manufacturers were required to demonstrate the effectiveness of drugs, to follow strict rules in testing, and to submit to the FDA any reports of adverse effects from drugs already on the market. Manufacturers were also required to list drug ingredients by generic name in labeling and advertising and to state adverse effects, contraindications, and efficacy of a drug. The Drug Abuse Control Amendments of 1965 required accounting for drugs with a potential for abuse such as barbiturates and amphetamines. The Controlled Substance Act of 1970 replaced the Harrison Narcotic Act and the Drug Abuse Control Amendments to the Food, Drug, and Cosmetic Act. The Controlled Substances Act is extremely important because it sets current requirements for writing prescriptions for drugs often prescribed in dental practice. The Food and Drug Act of 1906 was the first federal law to regulate interstate commerce in drugs. The Harrison Narcotic Act of 1914 and its amendments provided federal control over narcotic drugs and required registration of all practitioners prescribing narcotics. The Food and Drug Act was rewritten and became the Food, Drug, and Cosmetic Act of 1938. This law and its subsequent amendments prohibited interstate commerce of drugs that have not been shown to be safe and effective. The Durham-Humphrey Law of 1952 is a particularly important amendment to the Food, Drug, and Cosmetic Act because it required that certain types of drugs be sold by prescription only. This law required that these drugs be labeled as follows: Caution. Federal law prohibits dispensing without prescription. The law also prohibits the refilling of a prescription unless directions to the contrary are indicated on the prescription. The Drug Amendments of 1962, Kefauver-Harris Bill, made major changes in the Food, Drug, and Cosmetic Act. Under these amendments, manufacturers were required to demonstrate the effectiveness of drugs, to follow strict rules in testing, and to submit to the FDA any reports of adverse effects from drugs already on the market. Manufacturers were also required to list drug ingredients by generic name in labeling and advertising and to state adverse effects, contraindications, and efficacy of a drug. The Drug Abuse Control Amendments of 1965 required accounting for drugs with a potential for abuse such as barbiturates and amphetamines. The Controlled Substance Act of 1970 replaced the Harrison Narcotic Act and the Drug Abuse Control Amendments to the Food, Drug, and Cosmetic Act. The Controlled Substances Act is extremely important because it sets current requirements for writing prescriptions for drugs often prescribed in dental practice. Federal law divides controlled substances into 5 schedules according to their abuse potential, Table 1.2. The rules for prescribing these agents, whether prescriptions can be telephoned to the pharmacist and whether refills are allowed, differ depending on the drug's schedule. New drug entities are evaluated and added to the appropriate schedule. Drugs on the market may be moved from one schedule to another while changes in abuse patterns are discovered. The current requirements for prescribing controlled drugs, Controlled Substance Act of 1970, are as follows. Any prescription for a controlled substance requires a DE.A number. All Schedule If through TV drugs require a prescription. Any prescription for Schedule II drugs must be written in pen or invisible ink or typed. A designee of the dentist, such as the dental hygiene, may write the prescription, but the prescriber must personally sign the prescription in ink and is responsible for what any designee has written. Schedule II prescriptions cannot be telephoned to the pharmacies, except at the discretion of the pharmacist for an emergency suppy to be followed by a written prescription within 72 hours. Because Schedule II prescriptions cannot be refilled, the patient must obtain a new written prescription to obtain more medication. Certain states require the use of triplicate or duplicate prescrip. Tie-in blanks for Schedule IL drugs. These blanks, provided by the state, are requested by the dentist. After a prescription is written, the dentist keeps one copy and gives 2 copies to the patient. The patient presents these 2 copies to the pharmacist, who must file 1 copy and send the other to the State Board of Pharmacy. These consecutively numbered blank prescription pads provide additional control for Schedule II drugs. Prescriptions for Schedule III and IY drugs may be telephoned to the pharmacist and may be refilled no more than 5 times in 6 months, if so noted on the prescription. Package inserts, PIs, contain literature about the drug and is negotiated between the manufacturer and the FDA. The PI provides information regarding the chemical makeup of the drug, FDA-approved indications for use, contraindications, warnings, adverse reactions, drug interactions, dose and administration, and how it is supplied. Please now contain a highlights of prescribing information section that summarizes key information. This section is followed by the table of contents and the full prescribing information main section. The labeling changes were made because the existing labeling was too complicated and too long, and so finding important information took an unacceptably long time. The PI for any new drug or being rewritten for a new indication for an existing drug must include the new formatting. A black box warning is about a drug that the FDA has required a manufacturer to prominently display in a box in the PI. The intent of the black box is to draw attention to the specific warning and make sure that both the prescriber and patient understand the serious safety concerns associated with that drug. Generally, the FDA uses black box warnings to bring attention to potentially fatal, life-threatening or disabling adverse effects of different medications. Some examples of black box warnings include: January 13, 2011, manufacturers of prescription drug products that contain acetaminophen are asked to limit the strength of acetaminophen to no more than 325 mg per tablet, capsule, or other dosing unit. In addition, the FDA has required that a black box warning label be included on all packaging for acetaminophen products highlighting the potential for severe liver damage and a warning highlighting the potential for allergic reactions, for example, swelling of the face, mouth, and throat, difficulty breathing, itching, and rash. November 14, 2007, manufacturer of the prescription drug product rosiglitazone agreed to add new information to an existing black box warning regarding the potential increase in the risk of heart attacks for patients taking rosiglitazone. March 2, 2006, long-acting 2 agonists containing salmeterol zinaphote, Ceravent discus, and fluticasone propionate/salmeterol zinaphote, Advair discus, now carry the warning that their use may increase the risk of asthma-related deaths. The FDA approves the use of drugs for specific indications, which are listed or labeled on the PI of the drug. Any information or use outside the labeled indications is considered off-label. Prescribers are allowed for use a drug for an off-label use if good medical practice justifies such use, the use is well documented in the medical literature, and the drug meets the current standard of medical care. However, drug manufacturers are not allowed to bring up off-label uses when speaking with the prescribing practitioner or patient, nor can they distribute written material regarding off-label uses. Orphan drugs are developed to specifically treat rare medical conditions. Rare medical conditions with orphan status are diseases that occur in less than 200,000 people in the United States. The assignment of orphan status to a disease and to any drug developed to treat that disease has resulted in medical breakthroughs that may never have occurred because of the cost associated with the research and development of new drugs. Medications can be recalled from use by the manufacturer itself, at the request of the FDA, or by FDA order under statutory authority. Medications are recalled if there is reasonable probability that their use will have serious adverse health consequences or death. Patients taking a drug that is recalled should call their health care providers about the best course of action. Dental hygienists need to become familiar with the basics of prescription writing for the following reasons. Correctly written prescriptions save time for the office personnel, the dentist, and the pharmacist who must call to clarify an incorrectly written prescription. Prescriptions written carefully are less likely to result in mistakes. A record of the prescription should be included in the patient's record. Prescriptions should be written out and Latin abbreviations should be avoided to minimize the risk for errors. Some drug abusers, shoppers, search for dental offices that might provide them with prescriptions for controlled substances or prescription blanks that they can use to forge their own prescriptions. Every dental office should keep prescription blanks in a secure place. The prescriber's DEA number should not be printed on the prescription blanks but should be written in only when needed. The dental hygienist should watch to see that prescription blanks are not scattered around the office. If the dentist practices in a state that requires triplicate or duplicate prescription blanks for Schedule II prescriptions, pads for those prescriptions must be stored under lock and key to prevent them from being stolen. In pharmacy, the primary measuring system is the metric system. Solid drugs are dispensed by weight, milligrams, mg, and liquid drugs by volume, milliliters, ml. It is rarely necessary to use units other than the milligram or the milliliter in prescription writing. Occasionally grams, gm, or micrograms, ug, are used. In addition to the milliliter, the liter, L, is also used to measure volume. Although clinicians will direct the pharmacist to dispense a liquid preparation in milliliters, the pharmacist generally converts metric measurements into a convenient household unit of measurement to be included in the directions to the patient. Liquids are converted into teaspoonfuls, TSP or T, 1 teaspoon equals 5 milliliters, and tablespoonfuls, tablespoon or T, 1 tablespoon equals 15 milliliters. The pharmacist supplies a calibrated oral syringe or dropper for infants and younger children. Most liquid dose forms come with calibrated dosing cups for both adults and children. Household utensils should not be used. The dosing cups are available in 2.5, 5, and 10 milliliters volumes with milliliters marked along their lengths. The parts of the prescription are divided into 3 sections. They are the heading, body, and closing, figure 1.3. Heading. The heading of the prescription contains the following: information, name, address, and telephone number of the prescriber, printed on the prescription blank. Name, address, age, and telephone number of the patient, written. Date of prescription, not a legal prescription unless filled in with date, often missing. The name, address, and telephone number of the prescriber are important when the pharmacist must contact the prescribing clinician for verification or questions. The date is particularly important because it allows the pharmacist to intercept prescriptions that may not have been filled at the time of writing. For example, a prescription for an antibiotic written 3 months before being presented to the pharmacist might be used for a different reason from that the dentist originally intended. Likewise, a prescription for a pain medication that is even a few days old requires the pharmacist to question the patient as to why the prescription is being filled so long after it was written. The age of the patient enables the pharmacist to check for the proper dose. Body. The body of the prescription contains the following information: the Rx symbol, name and dose size or concentration, liquids, of the drug, amount to be dispensed, and directions to the patient. The first entry after the Rx symbol is the name of the drug being prescribed. This is followed by the size, milligrams, of the tablet or capsule desired. In the case of liquids, the name of the drug is followed by its concentration, milligrams per milliliter, mg/ml. The second entry is the quantity to be dispensed, that is, the number of capsules or tablets or milliliters of liquid. In the case of tablets and capsules, the word dispense is often replaced with hashtag, the symbol for a number. When writing prescriptions for opioids or other controlled substances, the prescriber should add in parentheses the number of tablets or capsules written out in longhand. This practice reduces the possibility that an intended 8 could become an 18 or 80 at the discretion of an enterprising patient. Directions to the patient are preceded by the abbreviation sig, Latin for signa, right. The directions to the patient must be completely clear and explicit and should include the amount of medication and the time, frequency, and route of administration. The pharmacist will transcribe any Latin abbreviations, Table 1.3, into English on the label when the prescription is filled. Closing. The closing of the prescription contains the following: prescriber's signature, DEA number, if required, refill instructions, After the body of the prescription, space is provided for the prescriber's signature. Certain states have more than one place to sign. Certain institutions also provide a space on which to print the prescriber's name. This is not necessary for dentists with their own prescription blanks. If there are several dentists in one office, the names of all the dentists in the practice should be included on the prescription blanks. Then the individual dentist should check a box or circle his or her name so the pharmacist will know who signed the prescription. In addition, the law requires that all prescriptions be labeled with the name of the medication and its strength. Figure 1.4 is a sample prescription label. This labeling allows easy identification by other practitioners or quick identification in emergency situations. One should note that the name, address, and telephone number of the pharmacy, the patient's and dentist's names, the directions for use, the name and strength of the medication, and the original date and the date refilled, are required. The quantity of medication dispensed, number of tablets, and the number of refills remaining are noted as well. If a generic drug is prescribed, then the generic name of the drug and the manufacturers are also required to be shown on the label. If the trade drug is used, only the trade name must be shown. In most states, before a dentist can legally write a prescription for a patient, the following two criteria must be met. Patient of record. The person for whom the prescription is being written is a patient of record, no next-door neighbors or relatives, unless they are also patients of record. Dental condition. The condition for which the prescription is being prescribed is a dental or related condition, no birth control pills or thyroid replacement drugs. Abbreviations. A few Latin abbreviations are used in prescription writing to save time. The abbreviations also make alteration of a prescription by the patient more difficult. In some cases they are necessary to get all the required information into the space on the prescription form. Some abbreviations that may be useful are shown in Table 1.3. If abbreviations are used on a prescription, they should be clearly written. For example, the three abbreviations GD, every day, G.O.D, every other day, and Q.I.D, 4 times a day, can look quite similar, and choosing the wrong one could be disastrous. Electronic prescribing, e-prescribing, is the electronic transmission of a prescription to a pharmacy, which reduces the incidence of errors in reading handwritten prescriptions and the patient's ability to tamper with a prescription. Electronic prescriptions are uploaded to a transaction hub, which provides the common link between the prescriber and the pharmacy, thereby reducing the risks associated with traditional prescription writing. Once in the hub, the information is sent to the pharmacy benefits manager, who assesses patient eligibility. Once this step has been completed, the prescription is sent to the pharmacy, which in turn notifies the prescriber of receipt of the prescription, figure 1.5. A written record of the prescription is kept in the patient's record. Prescriptions can also be faxed to a pharmacy. The inclusion of e-prescribing in the Medicare Modernization Act of 2003, MMA, gave momentum to its use in provider practices across the country. The MMA expanded Medicare to include a drug benefit program, Medicare Part D, which began in 2006. Patient adherence to medication therapy is vital to the success of therapy. Adherence to therapy implies that the patient takes the medication as prescribed. Many different factors can contribute to non-adherence to therapy. They include poor understanding of the disease and a need for medication, fear of medication side effects, distrust of healthcare professionals, economic factors, and forgetfulness. Also, the longer the duration of therapy and the higher the number of times a day the patient must take a prescription, the higher the risk for non-adherence to medication therapy. The dental hygienist should be able to answer the patient's questions about the prescription and should make sure that the patient knows how to take the medication prescribed, how long and when, what precautions to observe, drug interactions, possible side effects, driving limitations, and the reason for taking the medication. Information about the consequences of non-adherence should be included. A patient who is informed about the prescribed medication is more likely to adhere to therapy. A patient should never get home and not know which drug is the antibiotic, for infection, and which is the analgesic, for pain. Side effects, such as drowsiness and stomach upset, should be noted on the label.